I'm Dr. Boucher. Welcome back to Hernia Hub, your favorite place for no-nonsense hernia advice. Today we're talking about a special topic: why do hernias come back? So I fielded more questions from my patients and compiled them for something that I think would be a high yield. So the first question of how common is a hernia recurrence? And just for getting some common ground, when we talk about recurrence, that just means hernia has come back. So it varies by type. And so in general, groin hernias come back pretty infrequently. It depends a lot on the studies that you quote for this. So unfortunately, I'm going to be giving you like a range of numbers for these kind of things. But in general, the chance that a groin hernia comes back, and that's, whether it be a high quality non-mesh repair or mesh-based repair, open, laparoscopic, robotic, we're assuming that all of these surgeons are out of their learning curve. They're all very good at what they do. And so we're taking like earlier, career surgeons out of this equation. In general, for groin hernias, it's around a 1% to 7% recurrence rate, which is pretty good. Really doesn't get much better than that. So groin hernias come back, 1 to 2 to 7% of the time. We're talking about abdominal wall hernias. Abdominal wall hernias are a different breed based on how big they are and whether or not it's from an incision or not, like whether or not the hernia is from previous surgery. In general, if we're talking about a small umbilical hernia, less than 2 centimeters in size, those have a pretty low chance of coming back, somewhere around like the 1 to 10% range. And that depends how it was done, right? So did you do it with mesh? Did you do a suture-only repair? The bigger the hernia gets, the bigger the chance the recurrence is, right? So if you have a humongous abdominal wall hernia, we're saying, a foot wide hernia, 12 inches or so, like an enormous hernia, those have a relatively high chance of coming back, unfortunately. But when those come back, recurrence, sometimes it recurs completely and the whole thing pops back open ultimately. Sometimes they come back smaller, right? You fix a large abdominal wall hernia and then someone gets like a 2 centimeter recurrence. That who cares about that? That's relatively easy to fix if the patient is even symptomatic from that. But in general, the take home here is that the bigger the hernia is to begin with, the higher the chance the hernia comes back. And I know, I've seen some surgeons, especially like, social media stuff advocating for that's why they would recommend fixing all small hernias because if you let them get bigger, then they're harder to fix, which I agree with that sentiment in general, but I do not think it's a reason to push people to fix relatively asymptomatic small abdominal wall hernias. If someone sees a hernia getting bigger rapidly, they'll tell you, and that's like part of your discussion when you see someone with a relatively small hernia that they're asymptomatic from is like, we don't have to fix it. The chance of an emergency is low. If it gets much bigger, we should fix it. So if you notice it getting bigger, come in early and we'll get it planned to fix. Because like if you have something this big, that is relatively easy to fix. If it gets this big, that's relatively hard to fix. But if it goes from this to this, that's not really a huge deal. And I think most patients kind of know their body, know themselves, and they'll come see you when they notice it getting bigger so you can get it fixed, especially if you've established a good relationship between patient and surgeon. So question 2, what are the most common reasons hernias come back? This one's tricky. And this is where I feel like sometimes in clinic, patients push for an answer like, why did my previous surgery fail? And again, it's hard to answer those questions. But in general, the main tenets for hernias coming back are, is it a technical error? Is it a patient factor? Or is it sort of like genetic hernia related? And we'll talk about all three. So essentially, like the technical one, that's what I care about, because that means like, did I mess up? Did I do something wrong? Anytime you bring something very large together, that closure is going to be on some degree of tension, right? Meaning like if you take two edges that are far apart and bring them together, the tension is wanting to pull that back apart. So like the sutures that you put in have to take those two layers of tendon, your anterior rectus sheath, together, and then your body does the fusing. It sort of like welds those two areas of tissue together. And so like your body is doing the actual like hernia repair, like after our job of putting that tissue together, reinforcing that with mesh, your body is like fusing that fascia together. And so our job is to have that closure on as little tension as possible. And so what does that mean of like making the right decision for what kind of surgery to do? So if you have a big hole, you can't just sew the hole closed and high five and like go to lunch. You have to do some more advanced techniques like muscle releases, which we call like a transversus abdominis release and anterior component separation to bring that tissue together. And so making sure your repair isn't on too much tension would be thing number one. Number two is using no mesh, the wrong mesh, or an inadequately sized mesh. And in hernia surgery now, there's no agreed upon rule, and I've talked about this before, where if you have like a 2 centimeter hernia, in general you want to add 4 centimeters all the way around to that size of hernia, and that's before you close it, and that's how big you want your mesh to be. There's really no data driven behind that number. That's just what most hernia surgeons shoot for. Is that probably overkill for smaller hernias and probably a little underkill for large hernias? Yeah, for sure. I think the bigger the hernia is, the more important having a nice, big, wide mesh overlap is. Why do some surgeons not advocate for wider mesh overlap? It could just be a philosophical difference in opinion, or it could be that like you have to make space for that mesh to go, and you have to suture that mesh in. You have to create that pocket for it, and it's hard. It's really hard to make a big pocket, especially in a hostile abdomen. I think that's why some people shy away from putting bigger mesh in sometimes. But the bigger the hernia, the bigger the mesh needs to be. The mesh just can't go to the edge of your hernia, and that's it. It's not like the foundation that your home is sitting on. It needs to be wider than the actual area you're trying to cover, because mesh contracts over time. Right, we think that mesh contracts up to like 30 to 40% of the time, and if you use too small of a mesh and it contracts, then it's part of the defect is left uncovered, and then that sets you up for a hernia recurrence. Missed hernia defects, meaning a hernia that was not repaired at the time of surgery, is I think it's missed a lot, and I think that's how robotics is really helping with surgery now, because if you can imagine, if you're doing a surgery open, meaning you just make an incision over the hernia, you push that stuff back in, you sew the hole closed, plus minus mesh, whatever, and then you get out of there, you really only see what you're cutting down on top of. You can't see anything else anywhere else. So I can't tell you how many times I've gone in for like a robotic hernia surgery, like a minimally invasive surgery from the inside. And yeah, we see that main defect that we're there to close, but we also see other holes, like little hole here, little hole there, above and below that main hernia at the midline. And if I was doing that surgery open, I wouldn't have seen that, because you can't see it because you're looking from the outside in. When you're in the belly looking up at the abdominal wall from the inside out, you see everything. You don't miss anything. And that's, to me, one of the reasons why I usually do even small abdominal wall hernias robotically, because you find stuff you would have missed all the time, and then you can address it. You close the hole, you make sure that defect is covered with the mesh as well. So I think that missed defects are a huge reason for what is perceived to be a hernia recurrence. Because like say you have hernia here and smaller hernia right above it. Even if you did a great job fixing this one from the outside and that one didn't come back, if the one right above it comes back, it's close enough. And everyone's going to think like, oh, that was the same hernia that came back. Why in the world would I think there was a smaller hernia like right by the first one? So it gets blamed as a hernia recurrence a lot, whether it be appropriate or inappropriate to judge that. All right, so those are the technical errors, right? Making the right decision for what kind of surgery to do, make sure the mesh overlap is wide enough, and making sure that you're not missing any adjacent hernia defects. Part two is patient selection, right? I think a humongous reason why hernias come back is because that operation shouldn't have been done on that patient at that time. So what do you need for a good hernia repair outcome? One, BMI less than 40. A little nuance there, but let's just say 40 for now. So if you're 600 pounds, 6'1", you should not be having an elective hernia surgery. This is not talking about emergencies. Emergencies are out the window. This is an elective planned hernia surgery. If your weight is too high, there's too much force pushing from the inside out, it's going to pop that hole right back open, right? Super high recurrence rate for a BMI much over 40 if you're doing hernia repairs. Smoking. You should not really be smoking before and after your hernia surgery. A little bit of debate about this for groin hernia surgeries, but for abdominal wall hernias, we at my institution, and my personal belief is you should stop smoking for 4 weeks before and 4 weeks after your surgery, so you can deliver the maximum amount of oxygen to your tissues that are trying to weld together, and that can give you the best setup for hernia non-recurrence. Diabetes under control, hemoglobin A1C less than 8, 7.5, a little nuance there, but you shouldn't have rip-roaring diabetes uncontrolled when you fix your hernia surgery, mostly for an infection perspective, right? If you get a wound infection where your mesh is after your hernia surgery, the chance of that hernia recurring are very high. So do everything you can to decrease the infection potential, which is controlling your A1C. Heavy lifting after surgery, I personally don't think that's a huge deal. A lot of surgeons do. I would say I'm in the minority of people who don't think that's a big deal. I think that patients will self-select for the activities they feel ready for and don't feel ready for. Like post-op day 2 after your enormous hernia surgery, you're not going to go max deadlift, max squat. You're going to think, oh, I'm not ready for that. My belly doesn't feel ready for that. I'm just going to chill. I think, all the post-operative restrictions people do, and I tell people 40 pounds for 4 weeks just for something, because if you think of like what you would want as a patient, if your surgeon says like, oh, I did your surgery, go do whatever, like that doesn't instill a ton of confidence, and you want some guidance, right? So I say nothing heavier than 40 pounds for 4 weeks, but I hate when people give restrictions of like, you can't lift more than 5 pounds for 6 weeks to, this mom who has 3 kids at home, and like, what are they supposed to do? Right? This is based on zero evidence. I'm telling you, you can't like lift up a gallon of milk from the grocery store. That frustrates me. Sorry for getting emotional about it. Okay. Other reasons why hernia come back are like after your surgery stuff. Say you did a great surgery, you were the perfect patient, did everything right. After surgery, say you gain 100 pounds. Life happens. No one plans on gaining 100 pounds. If you go from 200 pounds and your BMI is 40 and you gain 100 pounds, your BMI is like now 52. It puts more pressure on that repair from the inside out for all the same reasons we talked about before, and you have a chance of your hernia recurring, right? If you need additional surgeries after your hernia surgery, say, you're 50 years old, you had a big hernia, found a really good surgeon, did a really great job, everything's perfect. Lo and behold, you're 60 years old and you get something bad, like you perforated diverticulitis, you're septic, you need an emergency operation. They cut right through that mesh. They have to. There's no other way to get in your belly. And do whatever they need to do and sew you back up, and that's a really high chance of getting a hernia again. Just the way it is, and it's not 100%, 50-50. But that's one of those things. It's bad luck. You can't control it, right? We can't say, we'll fix your hernia and then you'll never need another belly surgery. I don't know. I think the way we're doing hernia surgery now is much easier to go back in minimally invasively and do surgeries. Like if you do a big hernia repair, a big TAR, and you go back and need your gallbladder out in 5 years, most of the time you can get in safely to do that. And that's a lot different than when we're doing open big hernia repairs. The adhesions, the scar tissue is a lot worse, and it's hard to get in your abdomen afterwards. But if you need this big emergency surgery after you've had a hernia surgery, higher chance of hernia coming back. And then this gets talked about a lot, and we don't have any great evidence for it, but like poor tissue quality, like genetic patient factors where your tendons are just not as strong as others. And I think like a little bit of that genetics is a little bit of that is lifestyle, right? So if you're super into fitness and you're working out your abdominal wall a lot, and your tendon is strong and your ab muscles are strong, you can take more, your abdominal wall takes more of a beating before you get a hernia than if you just kind of like lay around, don't do anything, and then your abdominal walls gets really thin and weak, and then you get this, you have a surgery and you have it repaired, but your tendons don't hold the suture as well, and it's more predisposed to get a hernia, right? We don't have great evidence for that. I wish I could be like, oh yes, we did a study where we looked at people who get hernias and their rectus muscles are thin, like 1 centimeter in size, and people have like 2.5 centimeter or greater width rectus muscles don't get hernias as much. We just don't. That's just my anecdotal take. And then we talk about things like, collagen disorders, don't have as much collagen in your tissue. Should we take like collagen supplementation, blah, blah, blah. We don't have any good evidence for that either. I think that some people are genetically predisposed, especially for things like hiatal hernias, where it's more genetic than we think. But like type 1 collagen, especially for hiatal hernias. But either way, those are things that we can't do anything about. And so to me, there's no point in really worrying about that. But if someone wants to ask like, hey, why am I so prone to hernias? You'll see people like that. Like, oh, I've had like 10 hernias. Why me? It's like, oh, well, I mean, it could be a little bit of genetics. And I think that's a totally reasonable explanation. Okay, so those to me are the most common reasons why hernias come back. Next question, does using mesh prevent a recurrence? Yeah, for sure. I think, we talked about that a little bit, and the size of the mesh matters. The type of mesh matters too, because I think the majority of mesh should be polypropylene. And then if depending on the technique that you use, you may need a coating on top of it if you're doing an intraperitoneal or IPOM repair, so that polypropylene can't touch the bowel, so the bowel can't get really stuck to that polypropylene and cause issues long term. But done the right way, polypropylene is very safe and integrates very well in your abdominal wall, significantly decreases your chance of a hernia recurrence. I get a lot of people ask me like, do I need mesh used for my small hernia? And to me, I think no. But if you have a small umbilical hernia, less than 2 centimeters, and you have like a, say, 5 to 10% chance of that hernia coming back without mesh, some people think, oh, I don't want to risk the mesh. I don't want to put the mesh in for something that has a 90% chance of not coming back. And fault that reasoning at all. And this is something that surgeons disagree about all the time. There's big names in the hernia world that just completely disagree about these topics. I would personally do more and put that mesh in a nice, safe space where I can take your hernia recurrence rate from what I think is 10% to something down to like 1 to 2% for something that I think is incredibly low risk. That's what I would want. But I talk to patients about this, right? I don't say like, I'm going to put mesh in you or else. I say like, this is a chance of the hernia coming back if we do. This is the hernia chance coming back if we don't. And we pick together. Now, you get to choose. This is your show. This is the patient's show. It's not my show. Okay. Why do some people have multiple recurrences? Tough question. Each time a hernia comes back after surgery, it has a higher chance of coming back again. So it's kind of like a negative spiral of surgery stuff where, you had a small belly button hernia fixed with sutures only. You say your BMI is 45, the surgery shouldn't have happened. The hernia comes back bigger. The hernia comes back bigger because it tears at the suture point usually, right? A hernia never comes back after a primary repair the same size. It always comes back bigger. I'll die on that hill, I think. I would say it always comes back bigger. Now, if the that hernia comes back, you have it fixed again. The hernia comes back, you have it fixed again. Not only does your abdominal wall get weakened every time you have an incision through it, we think that every time you make an incision through any tissue, muscle, skin, fat, fascia, tendon, if it heals perfectly, perfect suturing, perfect healing capacity, had protein after surgery, you worked out before, you waited and worked out after, the most that tissue is going to have the tensile strength it was before, 85%. 85% strength of what it was before, right? It's never going to be as strong as it was. So if you have 7 surgeries, like 85% of 85% of 85% of 85%, you're not left with much at the end of that, right? So if you're on your 5th hernia surgery, like something is, take a step back and like, what am I doing here? Why am I doing the same thing over and over, expecting a different result, right? So that's when sort of like pull out all the stops. If, say it's your 3rd hernia recurrence and it's not that big of a hernia, but you maybe go a little bit more overkill with the mesh overlap for that procedure, and those kind of things go into like sort of complex decision making. Once a hernia has come back twice, that's when like I'm in clinic, I think like, oh, this is something we need to like really be super overkill with, very thoughtful about, and do something that gives us the best chance of that hernia not coming back. Another point too is like once you've had multiple hernia surgeries, say multiple of those surgeries have involved mesh, then you have mesh in multiple different locations and you sort of have burned bridges, right? Because not only does it increase the inflammation and scar tissue in your abdominal wall and your abdomen, you now have mesh in a spot that maybe you can't go back in, right? A good example of this is you've had a previous like a TAR or a previous retrorectus repair and you have, rectus muscle, mesh, and posterior rectus sheath, and then you have a recurrence, it's really difficult to go back into a subsequent retrorectus repair. And so that's in surgery we talk about sometimes don't burn your bridges, meaning like do what needs to be done, but leave a backup option for next time if you have to come back for a reason, right? That's like we're not doing retrorectus TARs for like 4-centimeter defects. Like that's overkill. If that hernia comes back, we're not really going to have a good option of what to do next, right? We don't want to pull out the big guns for a small problem. Okay. Next question. If my hernia came back, does that mean the first surgery was done wrong? Yeah, and that's a super tough question. And I would, like I said, I never judge another surgeon, especially in front of a patient, but that's not necessarily the case, right? Even well-done repairs can fail. Sometimes we have difference of opinions about how that first surgery should have been done, but some things are not preventable. If you came in with an emergency, if you had a bowel obstruction and a hernia and that operation had to go in the middle of the night, and there was an abscess or, poop all over the place and you couldn't use mesh and stuff like that, and that hernia comes back, no one's wondering why the hernia came back. Emergency laparotomies that are dirty cases have up to a 60% chance of an incisional hernia. And, say that dirty case was from a bowel obstruction and a hernia with dead intestine, and then you went and did that case, like no one's going to judge that hernia that comes back, right? You should do the thing that's life-saving and not care so much about if a hernia comes back ultimately, right? So some things are preventable. Next question, is repeat hernia surgery more complicated? Yeah, we talked about that. Scar tissue, altered anatomy, previous mesh, high risk of complications, all that stuff. Next question, how do you fix a recurrent hernia differently? We've kind of talked about this. One point though is that if you've had a previous open hernia surgery, like incision from the outside, if it recurs, you're going to want to go back in minimally invasive to avoid all that scar tissue in those other planes. There's exceptions, but that's pretty much the rule, especially for groin hernias, for inguinal hernias. If you've done open, you have a recurrence, do it laparoscopically. If you had a laparoscopic repair and it recurred, you want to fix it open. If it comes back again, then it's a little awkward. I would say go back minimally invasive again. Next question. What can patients do to reduce recurrence risk? Great, right? That's what you should care about. Pick a surgeon who does this a lot. Get your BMI below 40. Don't smoke, ideally 4 weeks before and 4 weeks after. Control your diabetes as much as possible. That's it. I say some stuff that's like a little bit in the weeds, like my opinion, that's not based on evidence at all, is, post-operative protein intake, super important, because protein is kind of like that building block for, what we need to help like fuse that tissue, weld that tissue together. And that's just, you should really try to do that before, like starting 2 weeks before, like really get those stores built up, get your protein intake as high as possible, get nutritionally optimized before surgery. And we don't talk a lot about nutrition optimization for elective surgery because hypothetically those people are coming in nutritionally optimized, right? But sometimes you're not. Sometimes, especially if like you're in a weight loss period, like you've just lost 50 pounds to get your hernia surgery, like what if you've been starving yourself for 2 weeks just to hit that number, right? So it's important to kind of parse through that and make sure that we are not going into this operation, cachectic, Okay. When should I see a specialist for a recurrent hernia? I mean, I think if it's a first-time recurrence and it's still relatively small, that can be managed by most general surgeons. Totally fine. I think when you start getting past your second recurrence, or if your defect is larger than, say, like 6 centimeters, that probably is something that should be taken to somebody who does hernia surgery specifically. Okay, cool. I think that's enough. Thanks for joining us on this episode of Hernia Hub, talking about why hernias come back, and I'll see you next time.